allows you to control for some other variables. And you may be thinking, well, there's other things going on in the wintertime. Most obvious might be that the temperatures are colder during the wintertime, or maybe the humidity is drier. If you know someone with asthma, those are things that they don't like. There are other pollutants that tend to track along with PM. In the wintertime, our carbon monoxide levels are higher. As Jennifer mentioned, nitrogen dioxide is a traffic-related pollutant, just like PM 2.5. And then if you look at hospital data, you'll see that there are different trends on different days of the week, and that things really change on holidays. So we have to account for these different variables, and these models allow us to put them all in there together with PM 2.5 and get a better understanding of what the interactions are, and if we really are seeing the effects we think we see. There are limitations, however. There are things that we could not include, data that we did not have. We don't know anything about potential viral infections. We know that RSV and cold viruses seem anecdotally to be related to asthma hospitalizations. We didn't have bioaerosol data. You'll hear more about that tomorrow, about pollens, and you heard Jennifer talking about fungal spores, and everyone's talking about endotoxins, so we can't look at that. And there are a host of other factors, like personal activity patterns that would determine their exposure levels, or other factors that we don't include. So we do the best we can. The outcome from this model is something called a relative risk, and it's similar to the odds ratio Jennifer showed. And we're defining that now to give you more specifics. The relative risk is going to be the percent change in hospitalizations compared to the baseline rate. And for all of our examples, the baseline rate is going to be that lowest concentration of PM. So for the first example, it's going to be 0 to 15 micrograms. And if we see a relative risk of 1.5, that's basically saying at that concentration range, there are 50% more hospitalizations due to your factor, due to your variable. We're looking for two things in these graphs, and I'm going to show you several of these graphs sort of as our results. One is, are they significant? And as Jennifer showed, they're going to be black lines called confidence intervals. And those confidence intervals have to be above our baseline. And I'll show you where the baseline is. It's basically set at 1. The other thing is, do we see a dose response? So as we move up in concentration range, do we see an increase in our relative risk? Okay, I don't know if this is translating well, but I'm going to take just a minute to explain this, because there are 5 or 6 of these graphs that I want to show. The relative risk is on the vertical axis. That red line is our baseline hospitalization rate, and it represents the lowest concentration range of PM 2.5. Those first 3 green circles are Modesto, the next 3 are Fresno, and the next 3 are Bakersfield. And each progressive one goes from yellow to orange to red. So the first 3 green represent the second, third, and fourth highest concentrations in Modesto. And while we see some increases in Fresno that are above that line, we don't see that dose response that we would hope to see. This first box represents the 0-day lag. So this would be exposure, hospitalization on the same day. The second box here is with a 1-day lag. And the third box here is with a 2-day lag. And again, I just wanted to remind everyone, in these examples, we're controlling for a lot of other variables. And what we did see very strongly with a 1-day lag is that there was a pretty good increase in hospitalization for asthma in Fresno. And this accounted to about a 22% increase, even at the moderate PM levels. So from 15 to 30 micrograms, we still saw a 22% increase. And that gradually went up to 35 and 44% at the higher concentrations. We saw a similar good response with a 2-day lag, though it was not as robust. And we didn't see this in Modesto, and we didn't see this in Bakersfield. But if you look at the very last bar, there is an increase, and it is significant for Bakersfield with a 2-day lag at the highest concentration of PM in this example. One other thing we have to consider, and I mentioned this a second ago, is that the PM may be correlated with one of the other factors. In this case, this shows you the correlation between PM and our other variables. And that 0.574 says that carbon monoxide and PM are highly correlated. And even though our models try to account for this, they can't really disentangle which is wagging the tail. So it could be the CO is actually responsible for the effects and not the PM 2.5. And so we ran the same analysis I just showed you, this time actually using the quartiles, using 25th percentiles of each of our variables. And I know these are busy graphs, but it's the exact same as prior. The first set are all same day, the next set are 1-day lag, and the final group are 2-day lag. But this time we start with PM 2.5, and then we have carbon monoxide, nitrogen dioxide, and temperature. And what I'll point out is the only significant finding was with PM 2.5 at a 1 and 2 day lag. And carbon monoxide showed absolutely no effect on hospitalizations in this particular model.
And Tim, it's a little different though. You just put Fresno up in this one where you had all three in a
right. So because we didn't see much of an effect in the other two cities, we wanted to look more closely at Fresno and see, is the PM effect real or is it maybe attributable to another pollutant? So now going back to really quantifying that impact in Fresno, we need to look at the full spectrum. We can't just look at our 15 micrograms. So now I am going to use these quartile rangers with 25th percentiles that I showed before. And this is the same graph, and we really see the same response. But the concentrations are a little bit different, or I should say the relative risk is a little bit different, though somewhat similar. And we still don't see an impact in Bakersfield or Modesto. And we tried to estimate the cost that would be associated with this. People always ask me, so what does this mean? And that sort of next to the last, that number 81 down there, represents the annual increase in asthma hospitalizations that we would attribute to PM 2.5 over 17 micrograms, and that's a 24-hour average. And that's the combination of our second, third, and fourth quartile. So everything above basically our baseline concentration. And just for fun, we calculated that comes to about $1 million in healthcare costs. And compared to Fresno, this is for Fresno and Clovis population, it represents about 8% of the total cost for asthma hospitalizations, or 8% of asthma hospitalizations for the whole year. 13% if you're just looking at that October to March season. Oh, this is right. These next slides I can go through quickly because they're pretty much the same, but they're for emergency room data. And these may be a little bit different than hospitalizations. The one first difference is that we only have data from 2005 to 2007. That data was not available prior. It's just recently been collected and available for people to use in research. So we're only looking at a 3-year period. These are the same average daily asthma visits for ER visits, using 15 micrograms, and it's sort of the same story. Fresno, there's even a response at the same day, which we didn't see for hospitalizations, but it gets stronger with a 1-day lag. Nothing in Modesto, maybe a little increase in Bakersfield. And then at a 2-day lag, we start to see a little more increase in Bakersfield, and we see a little bit of the relationship in Modesto. So we follow that up with our more complicated regression model, and this again is all 3 lags for our 3 communities. And Fresno again was the strongest, but this time we saw a same day effect. And this maybe is something that makes sense if you think about an ER visit timeline versus hospitalization. It was again strongest was a 1-day lag, but we also saw a good effect in Bakersfield, but it was after a 2-day lag. And if people are interested, we have some hypotheses about why it would take longer in Bakersfield than in Fresno for people to go to the ER. And I think the obvious answer is healthcare, quality of healthcare. You can see something maybe a little bit in Modesto, but not really what you're looking for. And these are with the 15 microgram increments. If we now do our quartiles, which looks at the whole spectrum, Fresno is very strong, same day, 1-day lag, even 2-day. And now we see an effect in Modesto, both at a 0-day lag and at a 2-day lag. And for some reason, the effect in Bakersfield goes away. And that one, I'm not sure I can explain why we would see the Bakersfield effect anymore. So doing the same cost estimate for ER visits, and again, this is just for Fresno. We calculated a total of 273 additional ER visits for asthma for all concentrations over 17 micrograms. Estimates about $436,000 in cost. And very similar to hospitalizations, it represents about 8% of all asthma-related ER visits for a year. Well, I think what you heard is, people have been doing these studies for 10 years now, and what I showed you isn't really, it's new for Fresno, but it's not new around the world. People have seen these relationships in a lot of different cities and to different degrees. And what we really want to know is, are there parts of this PM that are driving the health effects? And maybe that'll help us explain why we see such a robust finding in Fresno and we don't see it so strongly in Modesto and Bakersfield. And so the next phase of our study will really just be